Yeah, absolutely. So patients with polycythemia vera are at increased risk for cardiovascular events. And one of the main ways we mitigate that risk and reduce their thrombotic risk is actually by controlling their red blood cell count or their hematocrit. This has been shown to reduce their risk of thrombosis by about fourfold. But unfortunately, the way we do this a lot of times is we do something called therapeutic phlebotomies, where we actually drain them of blood repeatedly over and over and over to keep that number down. And not surprisingly, patients don't always tolerate that well. Oftentimes they feel very fatigued from the consistent taking of blood. It can produce fluid shifts that aren't well tolerated. And honestly, it ties them to the healthcare system, so they lose a little bit of that freedom. And so in this study, we actually were utilizing an agent called Rusfertide. So this is actually leveraging our understanding of iron homeostasis, and it mimics an agent called hepcidin. Hepcidin is like the master regulator of iron, and it actually is responsible for allowing iron to be distributed to the bone marrow for continued red blood cell production. Interestingly, Rusfertide, when it mimics hepcidin, actually binds to ferroportin, which is this protein that kind of shuttles iron to the bone marrow, actually downregulates that, doesn't allow iron to be delivered to the bone marrow. Therefore, red blood cells can't be made, and we're able to control the hematocrit without the need for these phlebotomies, just by restricting iron delivery to the bone marrow. We performed this study looking at patients with polycythemia vera who were requiring consistent phlebotomies to see if it was able to do that. In the phase 2 study, we saw a drastic reduction, and so it led us to do the Verify, which was the phase 3 trial. And again, compared to placebo, we saw the ability of Rusfertide to drastically reduce phlebotomy eligibility in these patients. It also really consistently controlled their hematocrit. And I think quite interestingly, it also improved some of their patient-reported outcomes, some of the symptoms they have associated with the disease, things that are challenging to treat, such as fatigue. We saw that there was more of an improvement in Rusfertide-treated patients than those with placebo, and we think it may be related to that impact on iron deficiency. Yeah, so the methodology for this study, this phase 3 study called Verify, we looked at patients who were requiring consistent phlebotomies, and they were randomized 1-to-1 to either go on Rusfertide or placebo in addition to their current standard of care. The primary portion of the study lasted 32 weeks. The first 20 weeks, we kind of dose optimized the Rusfertide, and then the primary endpoint was assessed from weeks 20 to 32. Thereby, the primary endpoint was the absence of phlebotomy eligibility, so the need for a phlebotomy, if you will. And that's where we saw the key differences. We also looked at key secondary endpoints, such as the ability to maintain a hematocrit less than 45% for weeks 0 to 32, and actually the mean phlebotomy rate over weeks 0 to 32. And lastly, the other key secondary endpoints looked at patient-reported outcomes. We used 2 patient-reported outcome tools called the PROMIS Fatigue Score, which really assesses fatigue and the impact it has on patients' lives, as well as the Myelofibrosis Symptom Assessment Form, or Total Symptom Score 7, which looks at things like fatigue, including night sweats, itching, abdominal symptoms, and bone pain. And in both of those, we saw significant improvements. Yeah, so right now our standard of care for patients with polycythemia vera is to offer them antiplatelet therapy with aspirin, therapeutic phlebotomy to maintain a hematocrit less than 45%, and in a subset of patients we offer them cytoreductive therapy. This could be hydroxyurea, interferon, or ruxolitinib in the second line. These agents are helpful in some sense, but all come with their own side effect profile, toxicity, and challenges in dosing. And here I think the impact of Rusfertide in clinic is that we won't have to necessarily do repeated phlebotomies in patients that aren't tolerating those. Here we can offer something that gives patients a little bit more freedom, maybe able to offer more consistent control of their blood counts to offer them increased thrombotic risk reduction. I think in patients that are dealing with problematic symptoms such as fatigue, and they're known to be really iron deficient from these phlebotomies, Rusfertide offers an option that can do a couple of things. It can control that hematocrit, control that hemoglobin, increase their freedom because they're not coming in and getting phlebotomies, and may address some of those problematic symptoms to let them have a better experience with their disease.